My name's Kim Nelson again, and I'm simply the moderator for our panel we have today. Heather Murphy from Wilkes County, Toby Gilbert from Onslow County, and Melissa Larson from Cumberland County. And this part of collective impact, where you try to identify root causes, is probably one of the most difficult, most challenging aspects of dealing with a wicked problem, because so many of these complex problems have multiple causes and lots of other problems that spring out from the original problem, and sometimes it's very hard to get to the root cause. So each team has its own priorities and their own methods for tackling the opioid crisis, their own set of strategies. So as they talk about these, we're going to do sort of a question and answer. As they talk about these points, please write any questions you have in the chat box, and we'll be sure to answer them at the end. So if you're ready to start, we'll go ahead and start with the first question. Why is it important to identify root causes? And Heather's going to take the lead on this one.
Sure. So collective impact is a framework, and it requires a commitment from key stakeholders who represent a broad cross-section of a community. So we come together to identify that common agenda and solve for that specific social problem at scale. Getting to that common agenda and solving for that specific social problem requires us to look deeply at both the symptoms of the problem and the underlying social systems or conditions that are at the root of those problems. In other words, what are the underlying conditions in our community that, if we realigned or reimagined, could cause a desired outcome instead of exacerbating the problems we're facing? So in Wilkes, we brought together doctors, lawyers, social workers, school teachers, jailers, and juvenile justice seekers, grandmas, granddaughters, people who use drugs, teetotalers, people of faith, people of science. And we all agreed, of course, that misuse of opioids is a huge problem for our community. But if only it were a simple problem, and if only the problem of opioid misuse didn't cause such a host of so many other problems, disease, crime, broken families, and if only getting to the root cause of opioid addiction was as easy as pulling up some nice greens and finding a pretty orange taproot that we could chop into a carrot salad and be done with. But, you know, people shouldn't do drugs, case closed, no problem, solved, next. But no, opioid misuse is more like a big old oak tree, casting shade all around our community with a deep, well-developed root system. Or a better analogy might be kudzu, designed to solve one problem, but created another one entirely, tangled and gnarly and complex. Roots that feed the beast while sucking the life out of everything around it. And so as a cross-sector of society, we had to examine both how we defined the opioid problem and our own deep-seated belief system about what was causing those problems. I dare say that through that process, we learned a lot. We learned that we didn't know what we didn't know. We learned to question our own assumptions. We learned that there was far more wisdom in the room than we could have imagined when we brought all of those people together. And as we began to see that connectedness and those entanglements, we could then trace them back to our own connectedness or a lack thereof. We study root causes because therein lies the keys to systemic and sustainable change. We don't just want to patch up the symptoms. My husband rides bikes, and I can assure you that if he ran smack into a tree, we wouldn't just bandage his boo-boos. We'd get his head examined. We'd make sure his steering column wasn't loose, or we'd fix his brakes. We'd do whatever it took to see that whatever caused it the first time wasn't going to repeat itself. We get to the bottom of root causes of addiction and overdose because it's the only way to find and fix what's really broken. And I say causes because there are many roads that lead us down the path of addiction. And understanding how we get there illuminates the roads to recovery, the path to prevention, the tracks to treatment. And those two are complex and intertwined. It involves our systems of care, our systems of justice, our recovery communities, our schools, our businesses, our governments. And systems function at their best when they share a common understanding, a common vision, and they work together on those mutually reinforcing activities. Addiction specialist Johan Hari wrote that everything we think about addiction is wrong. He says the opposite of addiction is not sobriety. He says it is human connection. In Wilkes County, we were blessed to have George Etheridge from the New York Times. He came down and he wrote a piece about Wilkes County entitled, "Feeling Let Down and Left Behind with Little Hope for Better." It's accompanied by a really striking picture of a guy surrounded by a cloud of vape smoke. And, you know, it really showed off Wilkes County pride. But wow, when we study root causes and we say that complex problems can only be solved by connecting those dots, the humans, the systems, the data, you know, we realize we have to do that together because no one should be hopeless and alone. No one should be stigmatized or ostracized. No one should live under the chronic toxic strains of being let down and left behind with little hope for better. In our community, we said that's unacceptable. Opioid addiction is a devastating scourge, but it is preventable and it is treatable. It's a treatable disease. And so we study root causes because that is the hope for our community, where everyone is healthy and safe and able to thrive. And if we can understand those underlying contributing factors for opioid abuse and addiction and overdose, then we can turn the tide on that scourge. We really learned that if our systems aren't working, that in and of itself is both a root cause of the problem and a key to its solution. So root causes are at the root of how we solve this problem. Thank you, Kim.
Thanks, Heather. Melissa or Toby, do you want to add anything about the importance of examining root causes?
Go ahead, Toby. You want to go?
Go ahead, Melissa.
I was just, you know, as Heather was describing their experience there in Wilkes County and how important it is to go through the examination of root causes, I sit back sometimes and I picture like someone with a like a wheelbarrow, or Lord, it escapes my mind what you put your kids in, but you know what I'm talking about. And you're going, was that?
A stroller.
Yeah, like a wagon, for example. And so you're going forward with your team and you're talking about all these symptoms and you're talking about what's plaguing the community at that moment and what your problems are. But if you go backwards with that wagon and you start looking at the root causes, that's where you get the total picture of where your prevention efforts should be, right? And not just thinking about what's here right in front of us, but going backwards and figuring out how can we make our citizens safer and our families safer and healthier. But yeah, so Heather, I think you nailed it there. And that just was the vision I was getting as you were describing that.
Yeah, and I would agree. I was thinking the same thing, Melissa, is, you know, sometimes when we're trying to look at, you know, what is the actual problem? You know, we're trying so hard to see what it is that we look past it, and sometimes we have to start at the top and actually work backwards to truly identify, you know, what is the foundation of what's really happening. And so I was actually, as you guys are talking about visualization, you know, mostly you're talking about the wagon or the wheelbarrow, and I was thinking of a Band-Aid and going to the doctor, and it's like, okay, I have this sore and I'm putting a Band-Aid on top of it, you know, but it just keeps getting bigger and bigger, and we just keep putting bigger Band-Aids and more Neosporin on it until it's so big. that we have to go to the emergency department, and then they're telling us, oh, you know, it's really a septic type of issue, and then trying to really get at the root cause from that way. So we try to manage it as best we can from the knowledge base we have, but until we start bringing in other people with other expertise or different perceptions, you know, we really don't know what we don't know until we get to people that know. And then they reach out to people that have more knowledge than them. So I think, you know, it just goes to that collective impact, and going back to the demonstration that Adam had in one of the slides where you have this confusion and, you know, kind of going through the communication basis of getting truly to that point where you have the individual, the isolation, and then moving forward to collective impact, and just how important that is, that on this major scale of opioid addiction and every other addiction process, it's not just our communities, just not our area. It is a nationwide issue, but how we here in North Carolina and the School of Government, Blue Cross Blue Shield really provided this opportunity, and it's really refreshing to see, you know, how far each team has come from where we started, in using this root cause analysis type of process through collective impact.
Great. And so while we're on you, Toby, what do you consider to be some of the root causes of the opioid problem in your community? And how did you guys make that determination?
It's a great question. You know, we really struggled when we first came to the School of Government. Our team really struggled with, you know, some of the root causes. Again, I think we had to work backwards, as we've been talking about. I think we all had ideas, and our team is a pretty diverse team made up of public health, government, law enforcement, substance abuse professionals, managed care. So we really had some different perspectives, but I don't think we had everything. And until we started pulling in, you know, a lot more individuals, that's what really helped us determine some of the root causes of the opioid crisis. And I think what really started it for us was when the report came out that showed our city and our county being number 12 in the nation for opioid prescription abuse. And that was a real eye-opener for us, because I don't think we realized just how much opioid prescriptions were going out in our county. So that really demonstrated to us, okay, this is a good starting point for us. This is where we need to put initial focus. But is it our underlying cause of everything? Or is that just where we start? So it was a great starting point. And once we were able to start bringing, you know, our hospital partners, our physician partners, our healthcare, and so forth, you know, it really helped us start to uncover some more problems well outside of just the prescription opioid issue. Being able to dig into, you know, the local law enforcement between the sheriff's office and the city of Jacksonville or Jacksonville PD, and start to uncover some of the trends through the overdose mapping systems that they share. Talking with our emergency crews, you know, our paramedics. We are fortunate enough to have had the pilot program, I'm sorry, with community paramedics that have since become more, they're now permanent. And we have two, and one is dedicated to substance use and abuse, and the other one is dedicated to elderly and some neurocognitive type stuff. But having that and being able to pull every EMS run for overdoses or deaths related to drug use or misuse, coupled with our QRT team, really allowed us to start pulling data there and starting to see some underlying root causes with respect to lack of education, lack of resources. Our EMS did not carry, none of us, nobody first responder wise carried Narcan, for example. Nobody had training in Narcan. Nobody, you know, there's a lot of people didn't know what Narcan was or what it did. It allowed us to partner with the harm reduction, you know, with Melissa, who will talk next. You know, she was very instrumental and her program was incredibly instrumental in coming in and helping us to start that program. It also opened us up to the LEAD program, which is really, concepts of it right now we've been using, but as far as the program, we're just now getting off the ground with her assistance. And, it has allowed us to network. So understanding that a lack of resources, a lack of education were some of the really big root causes for what was going on, and understanding that our physicians were not real tuned in to what other physicians were doing within the community. So they would have their medical meetings, but they were not truly understanding how they were managing pain, how they were managing, just simple pain problems. I work in the emergency department, and so we started paying attention to some of the reasons people were presenting to the emergency department. And it was interesting as we would, somebody would present, we'd pull up their prior visits, and what we would see is people were some would consistently present for tooth pain, ankle pain, knee pain. It was 30 or more visits for just pain-related complaints. And there really wasn't other complaints. So when we started kind of tracking what the physicians were doing with respect to treatment, and noticed that, they were constantly getting pain meds, we started to be able to find the pattern within that. And then we were able to address that through the emergency department, through the hospital and so forth, and put some new policies and stuff in place there. So, but through that, we also we were able to bring on new partners, the school, so forth, the health department, some other DSS, some other social service agencies. And in the course of our few years in working with the school of government, our task force now, for us, in Onslow County, we now have 39 partners, which initially when we started, we had about 12. So it has been very successful, and they have been amazing in helping us to move forward in the continuation and identification of not just opioid, but methamphetamine has become very big. As Adam was saying, addressing one may lead to opening doors of another, and that has certainly been an ongoing issue for us. So we now are addressing that. It's also allowed us to continue to seek additional funding to address these issues through our collaborative and our partnerships. So we were, and Melissa had the same opportunity down in her county, I know, to get a great deal of money through grants to continue these efforts and start some new projects and reach out to some other community partners. We were able to, I think we received a $900,000 grant, COSAP grant, where we were able to bring in about 6 different partners to do some different projects and to really partner with just this project in and of itself. So I think, prioritizing becomes your biggest key once you start to identify your root causes, because what you'll find is they'll start flying at you like, somebody's throwing rocks at you, because everything becomes really important. But you really have to figure out what is your priority, and then start addressing those and pick the most important ones to your community. And then, just continue your efforts and really keep people motivated. And what we found, I think, was the data. The data is what keeps us motivated because it shows us where people need the most help, and that we need to continue addressing that, because data is people. It's not just numbers. We look at it like every data point is a person. So that's what I have.
Great, thanks, Toby. We're going to move on to the third question, so we have time for questions to the group that's here. And I'd like you all to answer this, but starting with Melissa, what piece of advice would you give to someone who's considering starting a similar collaborative process?
Well, I have lots of pieces of advice because every group is so unique and every community is so unique. And our experiences that we found in Cumberland County, it was always changing. It's not like you just got this script and you come in and your group's already there and they're waiting and they have ideas and your action or strategic plan is developed in 1 or 2 meetings. Like this was a, you know, a collaborative process, and it took 2 years to get where we are today. With a fine-tuned action plan that we're moving forward on. But as far as advice, I think the biggest piece is patience. You know, when you're going in, like Adam said in the very beginning, and you're getting the right people to the table, you have to have patience in the entire process and make sure that each component has a lot of due diligence with it, getting those individuals to the table that maybe are prevention minded, for example, as you start working towards developing those strategies and you're thinking about root causes, do you have the right people there? Do you have individuals that are in the prevention world that are just really at the cusp waiting for some type of prevention campaign that they can engage in? And so it's knowing that your team may not have all the answers, but there's other people in your community that you can bring in that are already working in that particular wheelhouse. And when you have a large group like this and you're working towards developing those important strategies and identifying those root causes, you have to have patience and understanding that different ideas are going to come to the table. One of the things that we experienced in Cumberland from the very beginning is new faces coming in and out of the room. And so we would have a meeting or two and we would say, great, this is the direction that we're going. And then the next meeting you would have like 2 or 3 new faces and they would say, oh, but what are we going to do about this? And then the whole team kind of goes that way. And you have to bring back center and say, we have to at some point decide what our key strategies are and focus on those. And what the School of Government encouraged us to do is create a parking lot. So that parking lot was a big piece of paper on the wall that said, these are the ideas that we have that we're not going to be able to address today and now, but they're still important to the group and to our strategy, but we will have to perhaps come back to them. And so we use that parking lot strategy a lot, and it's probably time for us to go back and revisit our parking lot and see, did we integrate everything that we felt was important. And also those ideas that the different faces bring in is just understanding they're going to have their own opinions and ideas. And it's okay to disagree because we're not trying to get everyone to go in the exact same direction because we're all unique and all of our experiences are unique. So have patience when those opinions come in because you may be missing people at the table that you hadn't even considered. One of the big pieces for us was making sure that the recovery community was there. We can't develop strategies about people if we don't have those people at the table, right? And so that was important for us is to make sure that we were constantly reviewing our team members and the composition of the team to make sure that the right people were there. Be patient and understanding that you'll have to continually revise your plan, and that's okay. Different things will come up. For example, COVID came up with our Seafort team, our Cumberland team, in the beginning of the year. And so we were going in one particular direction as to having a resource card developed that we were going to pass out in the community that would talk about where you can access treatment, what the hours were. And then all of a sudden COVID came and we had to change direction in that and maybe not publish it at that time because it would be inaccurate, but develop something else that was more reflective of the time that we're in. And then I also want to talk about understanding those root causes, that those priorities may change over time. And again, that's okay. And just making sure that you're using your parking lot strategy and you're continually revising. When we got together in Cumberland, one of the things that the School of Government encouraged us to do was develop a mission statement right away. And that has served us really well because we wanted to develop a mission that could transcend the opioid epidemic. And the great thing about that is when we were developing our community or our collaborative team, they've been able to network and communicate and partner with each other outside of the opioid epidemic, which is what we want, right? So whatever that next issue may be, you already have these team players at the table and they know each other and they know how to communicate and contact each other. And so while you may have on your mind right now the focus of opioid epidemic, that, you know, you're keeping in mind that mission can transcend the current issue.
Great. Heather, Toby?
I guess I just want to take a moment to touch on what some of the root causes we found in our community to be. Toby mentioned prescription medications. Our first opioid epidemic in America was in 1914 when Bayer Aspirin created a product called heroin, based on the term heroisch from the German heroic, and it was to solve for pain for recovering people, you know, coming back from the war. And, you know, we didn't think heroin was going to be addictive, and, you know, but it was. And this epidemic is also an iatrogenic illness at its root. You know, prescription drugs have also led people down the road to heroin because they get addicted, they get dope sick, and then their supply is cut off. We also saw stigma as a huge issue. When we other addiction, when we say that's something that happens to someone else, you know, we create a situation where people can't talk about it. And if you can't talk about a problem, you can't solve for it. I mentioned economic decline. And when I first thought about that as an issue, I thought, well, how on earth are we going to address poverty? But we indeed now have programs around work to recovery and recovery as work. I know Toby could chime in on the adverse childhood experiences and trauma that families suffer under that creates multi-generational addiction. You know, we see that children of parents who are addicted often follow that same path. And then the whole idea of, if we are going to treat pain, then do we have access to non-narcotic pain management? Do we understand what works? So those are just some of the things that we identified as root causes.
Yeah, and to bounce in on that, Heather, you know, I think one of the things that you'll find as you go through this process, if you're considering, you know, hopefully you are, going through this process, is that it can become really overwhelming, I think. And I found with our team, and if my team members were here, I think they would absolutely agree, is that, you know, we started identifying all these things, and for a moment we were all like, whew, what are we undertaking here? Because there is so much. And we're like, where do we even start? Truly, where do we even start? Because, and part of it was a little bit depressing for us, because we felt really bad that our community was like in so much more need than we felt we could supply and that we could do. And what we needed to do, or what we decided to do to kind of pull ourselves away from that, was, you know, again, because our team was incredibly diverse and we all worked in, you know, really different government agencies or, you know, sections, is, you know, we just kind of kept reminding ourselves, you know, we're going to do what we can do for our piece of the world. We're going to prioritize exactly what is the highest priority here based on that data, you know. And again, data were people. And so some of that data was kids, you know, some of it was military members, some of that were, you know, obviously was young adults and adults. And so we looked at where was the highest need, and then that's where we started to address all of that seemed so high. And as Heather was saying about the adverse childhood events, you know, our foster care system, you know, most of those kids in foster care right now are the result of parents who are struggling with the substance abuse or addiction issues. And, you know, if we can address that, then it can have a more global impact, you know, across our state. And as far as moving them hopefully back to, you know, being placed back in their families with healthier families, which then again goes back to better healthcare, you know, because they're being overseen by by DSS and just on and on. So it all eventually, hopefully, will come together. But just if your team finds yourself getting into that position where you're feeling overwhelmed, all you got to do is take that first step somewhere, and eventually it will all tie back together. And I think that's, for our team anyway, that was very crucial, because it did feel overwhelming at one point, when we started to identify the issues that our county was experiencing as a result of number one, being on that report, being number 12 on that report, because that was the talk of the town for months, probably a year at least. So just, if you can, try to keep that in mind. At least that would be some of my advice going forward.
Toby, we had the same experience in Cumberland County when we created our action plan. It felt like it was 3 or 4 pages long, and basically what it was our list of things that we felt we needed to address: reducing injury and death, increasing access to naloxone, to syringe exchange, getting more justice involved programming within our community. And we just had to sit there and say, okay, how do we dissect this into a way that would actually be productive and fruitful moving forward? And we decided to break up into 3 different committees, and everyone got to select their own committee because we wanted them to be passionate about the work and not feel like they were assigned because of their professional background. And within each of those 3 committees, we had one that focused on medical and treatment, one that focused more on law enforcement and harm reduction, and then another that focused on prevention and community education. And we had each of those committees decide what was their priority and what goals and objectives did they feel like they were best suited to work on as a team. And then we would report back to each other. But definitely overwhelming for us too. And we didn't get here overnight, right? And we had to understand that we weren't going to quote unquote fix it or be able to be completely effective overnight either. And we probably have, maybe months, if not years, on some of our strategies. And so we start to see that data come out to say, yes, we were effective in our approach.
So to add to that, I think there are a couple of things. Someone has to hold the banner of optimism really high throughout this entire process. And you also have to be comfortable with the muddle, and in being in the midst of a complex tangle of issues, and know that you can look for the small wins that encourage people to go for the big wins, because you will overestimate what you can do in 1 year, but I definitely believe you will underestimate what you can do in 5 years if you stay the course. And so optimism, patience, and leaning into the discomfort of not knowing, I think, are all key components of doing this work.
Mm-hmm.
Okay, does anyone have any questions about how you would do this work, or about root causes or collective impact, or about the process we used here? Please enter questions. While we're waiting, if I'd like to know, this wasn't one of our original questions, but what surprised you guys the most as you've traveled this path?
So for me, when I created our team and I invited people from medication-assisted treatment, and they came to the first meeting and said that this was the first time they had been invited to the table to discuss substance use disorder. It is a gold standard of treatment, and yet they had been excluded from the discussion because people did not understand medication-assisted treatment. And that was a huge aha for me.
Yeah, that's really great, Heather. And we had something similar in Cumberland. We had a guest speaker come, and she was talking about recovery groups. And how she, as a patient of MAT, had always felt like she was not welcome at the groups. And I think it was an absolute eye-opening moment for our core team, because they had not heard that from individuals. They didn't understand that that's what people were experiencing out in the community, that great level of stigma. And so that was eye-opening for us too. Kim, to answer your question, one of the things that we experienced, or that I feel like I experienced with Cumberland, is that so many of the team members were communicating and connecting with each other outside of the meetings for other issues. And they said it was the first time that they had met someone or met that particular person and had been missing that connection for the whole time, and that this group brought them together. And I thought, well, that is just phenomenal. Sometimes when you're in the same community or profession, you make assumptions that people already know their partners, but they didn't. And so this really allowed them to work better together.
Yeah, and I'm going to tag on to that, Melissa, because I will say that we had that same assumption that people were already, connected outside of our group. And actually what we found, like you said, is that they weren't. I'd be talking about, one of our community paramedics, and somebody on our team would be like, who are they? Or I'd be talking to our community paramedic about one of our team members, and they're like, you need to connect me to her. I was like, you don't know her? And it was just amazing, that once you made that connection, once we made that introduction and that connection, then they actually were able to get a grant together between the two of them because of the type of the grant and so forth. And so these ongoing connections and networking has allowed for more things and programs to be implemented throughout our community, better resources, better resource guides, better, we were able to develop a website and a digest now that goes out through our team through the health department with all these resources and our partners now because of those social connections. And again, in each of our individual positions, we're able to provide this resource guide or a phone number and say, hey, or call this person, or here's some great resources for you to go forward with that we did not have prior to the beginning of this, or even meeting, many of these people through this collaborative. And it's not just within our county. I mean, we hooked our community paramedic up with Wanda, over in Durham on some things. So it's not just inter-county, it's outside as well. And it's been just an amazing experience doing this. So that has been not only surprising, but so beneficial and rewarding on top of everything else.
We are hoping that you guys won't just keep communicating with each other, but that as new community teams try to engage in a similar effort, they'll be able to reach out to you for questions and guidance as they go through this. Someone asked whether the school government is going to do another cohort. We have no plans to do that at this time. I believe there might be a collective impact process going on for a different issue right now. And we will be creating, as I said in the chat, we'll be creating a guidebook that will be on our new website that goes through each of the steps, and all those worksheets we created for you guys will be on there that they can use in their community meetings. And we also, we learned a lot from this process, right? We made some mistakes along the way. And so our guidebook will actually reflect what we would have done differently if we could do it over again. So we're going to switch over in just 5 minutes. Last chance for questions for our panel. If you have any questions, please add them to the chat.
I do just want to say there are a number of resources out there for people wishing to start a collective impact program. The Collective Impact Forum, FSG, the Aspen Institute. If you Google Collective Impact Forum, you're going to find a wealth of information. And it is a process that we use to solve any number of issues in our community: healthy eating, active living, resiliency. We've even started an outdoor economy work group. Boredom is a root cause of kids doing things that kids do. And